In the upcoming few slides, I would like to go over the basics you need to know about necrotizing enterocolitis and its radiographic appearance. It's believed that NEC is due to ischemic bowel and eventual bacterial invasion of the bowel wall. Early feeding with hyperosmolar, feedings of a premature infant plays a role. Risk factors are, as I said, prematurity, congenital heart disease, Hirschsprung's disease, and the presence of an umbilical arterial catheter. NEC usually presents within the first week of life with abdominal distension and vomiting, and then there are additional clinical features that we usually don't have access to as radiologists, such as metabolic acidosis, temperature lability, hypertension, and apnea. NEC most commonly starts in the right lower quadrant at the ileum and colon, with hemorrhagic necrosis of the bowel, which becomes dilated and friable. Eventually, gas bubbles appear in the submucosal and subserosal regions. Finally, the bowel may perforate, which can lead to sepsis, and in the long term, bowel strictures. For you to be able to recognize the radiographic findings of NEC, it is important to know how normal bowel looks like in a neonate. In a neonate, it's very difficult to tell small bowel from colon, but in general, the bowel wall should look polygonal, very soft and pliable, multifaceted, with no dilated, sausage-shaped, elongated loops of bowel visible. The earliest and the least specific radiographic finding of necrotizing enterocolitis is dilated loops of bowel, which do not change over time. These loops look tubular and sausage-shaped and may look very similar on follow-up abdominal radiographs. At this point, they would just hold the baby's feet and do not even start antibiotics yet, so this is a very safe thing to overcall for a radiologist. In the next phase of NEC, these dilated loops of bowel develop subserosal curvilinear or submucosal bubbly lucencies, which is called Pneumatosis intestinalis. Eventually, this gas may get into the portavenous system and may show up over the liver in the right upper quadrant. At this point, the patient does not require surgery just yet. So again, this is a fairly safe thing to overcall. At this point, the clinicians would stop the baby's feeds and start antibiotics. Surgery is indicated only once you see free intraperitoneal air. If you look at this image, you can recognize the bubbly and curvilinear lucencies projecting over the expected region of the colon, ascending colon here, and descending colon splenic flexure on the left side. There are also some curvilinear lucencies around the stomach, so that would be pneumatosis of the stomach. In the upcoming few slides, I would like to show you just a few quick examples of necrotizing enterocolitis so that you can use the imaging appearance of it. So if you look at this image, you can see some bubbly lucencies over the rectum and some curvilinear lucencies outlining the splenic fracture of the colon. These three images demonstrate necrotizing enterocolitis with bubbly and curvilinear lucencies here on the ascending, transverse, and descending colon. On the second image, the findings are more advanced with more linear lucencies outlining the transverse colonic wall and also the descending colon. Now, if you look further, you can see branching lucencies over the liver that represents air in the portal-venous system. And on the third image, you can see pneumatosis of the stomach and also pneumatosis of the descending colon, perhaps the ascending and transverse colon as well. However, most importantly, there is no free intraperitoneal air just yet. It is important to note that neonates do not form solid stool. The stool is more pasty, liquidy, therefore it should not be able to trap gas bubbles. So if you see stool on a neonate that looks like constipation, that is not constipation, that is necrotizing enterocolitis. This trick works up to about day 30, a 1-month-old infant, at which point they start to form more shaped and solid stool that might be able to hold on to gas within the fecal content. So again, this is a typical appearance of necrotizing enterocolitis on a neonate. As I mentioned it earlier, overcalling dilated loops of bowel is fairly safe because they will just hold the patient's tube feeds. At the next stage, when pneumatosis develops, they would hold the tube feeds and they would also start the neonate on antibiotics. However, no surgery is required yet. What you should not overcall is free intraperitoneal air because that is a surgical indication. This is a cross-table lateral view of the abdomen. So this is posterior, anterior, inferior, superior. Here you can see the diaphragm, and the image demonstrates free intraperitoneal air, which is visible against the anti-abdominal wall and the adjacent loops of bowel. You can also see pneumatosis in the lower pelvis. The gas from the bowel wall eventually may reach the portavenous system and show up over the liver as branching linear lucencies. This is one more example of portavenous gas. Again, you can see necrotizing enterocolitis, distended stomach. And this third one is just an example of pneumobilia on a grown-up. It doesn't really matter in a neonate whether you can differentiate the two from each other. The neonate has actually no business having pneumobilia. It is most likely portavenous gas. And the grown-up is very likely to have pneumobilia gas in the biliary system after a biliary intervention. And portavenous gas would show up only in a case of bowel ischemia. This is an advanced case of necrotizing enterocolitis with air within the portavenous system, and there is also free intraperitoneal air under the hemidiaphragms with the contiguous diaphragm sign. On the next image, you can see the football sign where the free intraperitoneal air outlines the falciform ligament. So all this is free intraperitoneal air. If you think about it, the baby is laying on her back, so the free intraperitoneal air is going to be at the most non-dependent portion of the abdomen, which is at the epigastric region.